Hello, everyone, and welcome to the breast cancer question and answer. Today's topic is ductal carcinoma in situ, and perhaps a few other things. I'm joined by Sharon Merritt. I'm Dennis Holmes, a breast cancer surgeon, and Sharon is a patient advocate. Sharon as before, has requested some questions from people that she's met through social media who've offered questions about DCIS. That's the focus of our topic, but it also provides an update of a couple of clinical trials that are ongoing that you should know about, specifically clinical trials related to ductal carcinoma in situ. Before we get started, do you want to share any words?
No, I'm doing good. Stage 4, but I'm doing good.
Well, thank you so much for continuing to provide leadership and inspiration to those who have sort of who've circled you in influence or who've become part of your global circle.
Well, it's kind of interesting because I'm supporting them, but they're supporting me a lot because having them and how much they tell me how wonderful I am and
Mhm.
how important I am makes me feel good, and that keeps me going, makes me feel better.
Well, thanks for
I don't even feel like I have cancer. I just feel like I have these, go to these infusions and stuff, and I still can't put my mind around it, except, it's on the scan, so I guess it's there.
well, keep living and keep inspiring.
I intend on
Thank
it.
you, and keep showing up for your treatments.
Oh, I show up for all of them.
Okay, thank you.
No problem with that.
So, the way this presentation will be slightly different than before. We have questions. Some of the questions will actually appear on the slide. And then there'll be some slides that I'll discuss that are relevant to the question. And then we'll move to the next question and we share the next set of slides. Okay. So let's start with the first one.
How does DCIS develop?
It's an excellent question. Well, sometimes things are clear when you can describe it with pictures, not just words. And
Right.
so I'm going to show you exactly sort of how DCIS develops, at least how we understand development of DCIS. So what we have here is an example of a drawing showing kind of the progressive development of DCIS over time. The idea is that it starts from a milk duct. So this is a milk duct or a tube that's lined by usually one or two layers of cells, although it might be a few more, but generally just a small number of layers of cells. And in the development of cancer, which can start even in your teens, doesn't have to wait until adulthood. There's some abnormalities that begin to develop in the cells, which are caused by mutation, which is represented here. The mutation causes the cells to start accumulating in a way that is atypical, meaning that ordinarily when the cells develop, they fluctuate with the menstrual cycle. They increase in number during the menstrual cycle, and then they decrease in number. So they kind of grow to prepare for milk production, and then when if milk doesn't person doesn't get
It goes
pregnant
away.
and there's no need for milk production, the number of cells decrease. So that's a natural increase and decrease. But atypia happens when the cells become abnormal and they don't decrease to the normal level. They sort of persist, almost like a pimple that forms where the cells are not cancer, but there's something about them that doesn't cause them to regress.
They're not normal.
They're not normal. We call it atypical in the case of breast. But eventually, those atypical cells may become dysplastic, meaning that they're starting to show some signs of cancer. And that's a type of abnormality that is what we would call atypical ductal hyperplasia in the case of breast cancer, that these are cells that are on the trajectory of developing breast cancer if the kinds of mutations that led to the development continue to happen. And in fact, what we see when these dysplastic cells continue to accumulate and continue to become increasingly abnormal is that we have a condition called in situ carcinoma or ductal carcinoma in situ, which is, we think of intraductal cancer or cancer that is confined to the milk duct. Now, one of the things I didn't point out, but I will now, is that there's this sort of this roadmap, if you can, or this wall, we call it kind of the wall of the milk duct. It's also called the basement membrane. It's the barrier that keeps all of the duct cells within the duct. The cells normally grow along the wall of the duct, but when they accumulate and become increasingly abnormal and form ultimately in situ carcinoma, the thing that makes the difference between in situ carcinoma an invasive carcinoma is whether or not the cells are able to breach or grow through this membrane. All of the blood vessels in the breast are outside of the milk duct. The lymphatic vessels are outside the milk duct. They're not within the milk duct. As you can see in this drawing, the blood vessels are out here. So this barrier forms a wall that keeps even these cancer cells from going to the parts of the body. But once they become invasive, the cancer cells, at least in theory, can have access to lymphatic vessels to go to the lymph nodes or blood vessels to go to other parts of the body. And that's why invasive cancer is a more severe condition than in situ carcinoma. To put it differently, if the cells never get a chance to leave the milk duct, they never have a potential to perform harm. But there's an important nuance that I must point out. In situ cancers don't become invasive just because the cells are within the duct. It means that they don't have the capacity to grow outside the duct. So even if you have a biopsy and a few of the DCIS cells built outside the milk duct, they can't cause harm because they don't have the tools to grow and set up a home elsewhere. It's really a kind of a matter of their maturation. It's almost like they haven't reached puberty yet. So even though they can be someplace, they can't produce more themselves.
So it's not that they get out, it's whether or not they've actually mutated.
Develop the mutations to live independently outside the duct. That's the key thing. And so, but once they've developed to become an invasive breast cancer, they have the tools to grow and live independently. And that's why they then move from the duct to other places on their own, and potentially can spread through the lymphatics or bloodstream, but hopefully we diagnose and treat it before that has a chance to happen. So sorry for that long explanation, but it's important to understand that it's a series of steps that may start as early as your teen years when your breasts are first developing, but might not develop into DCIS or invasive cancer until your 40s or 50s. It can be that long a process. And as the slide shows, it's a decades-long process. It's not a week or month-long process. So that's the first answer to the question. I wanted to show a couple of slides, these are actual pathology slides where the process has been caught in the act. This is what a DCIS, you're gonna see this a couple of times, but what DCIS looks like on a microscope slide. This is the outer wall of the DCIS. These are actually the cells, multiple layers of cells that have accumulated inside the duct. But you see almost like this dam breach where the wall is broken and you see these cells now pouring into or invading into the tissue outside the milk duct where there are blood vessels and so forth. So you actually sort of see the process of invasion. And this is actually the process kind of, if you kind of magnify this, you see this, again, this thick wall that has a DCIS cells inside, and this is the other side of the wall. And now you see that they're actually growing through and penetrating. These dark cells that you see here are actually immune cells that are trying to
Kill it.
We hope. Sometimes the
Trying
cancer
to.
cells are actually turning on the immune system to help them grow. So it's not always resistance, it's sometimes co-option, where the cancer cells are actually turning the immune cells into things that aid its development. But in any case, you see that there is an immune response to this process.
Can this be seen on a scan or no?
No.
Okay.
We're going to talk about what you can see.
Okay.
But this process of invasion, or the cells themselves, can only be seen in the microscope. So it requires a tissue sample in order to see this. The next question.
What are microcalcifications and how do they cause DCIS?
Okay.
Or do they cause it?
Yeah, so like it's a trick question. They don't actually cause it. But they do allow us to find it, and they are they do result from the development of DCIS. I'll explain that what that means in just a moment. So here we are back to the breast anatomy. We have it's kind of a drawing of the breast, and as you see, there's the lactiferous ducts, the ducts that are right below the nipple, and then they kind of extend into the breast, and they kind of branch. The ducts branch like the trees branch, and eventually you get out to the leaves, which in the breast we call the terminal ducts. which is the place where
The milk is made.
the milk is made, and the place where cancer generally forms, out near the far reaches of the milk ducts. Even though those ducts might be near the nipple, they're short ducts where there are branches and then a cluster of glands that give rise to milk. In any case, here we go. We have this terminal duct. And if you take one of these ducts and you cut it in half, you see once again it has this outer wall, this inner layer of cells, and then you have this accumulation of cells in the middle. What happens is when the ducts are first forming, the ducts are kind of small, but as the cancer forms in the ducts, it distends the ducts, and the ducts can sometimes double and triple in size. Since the blood vessels feeding the cells are on the outside of the duct, as the ducts become really, really big, they get farther and farther from the blood supply. And the ones in the center start to die because they don't get enough blood supply. And what happens is that those cells at the very center become calcified. Your body deposits calcium in the place where the cells are dying as a way of like forming a fossil, if you will, of DCIS. And so what I've shown in this image is kind of the formation of a calcium deposit that is accumulated in the center of a milk duct. And these calcium deposits form because these cells are no longer getting enough blood supply for them to survive, whereas the ones out near the outer surface of the duct have adequate blood supply. So let's show you what that looks like under a microscope. So here we have is, this is likely a normal duct right here. This thing that I'm showing you here is a normal duct. This is a duct that has DCIS. It actually has, the wall of it is shown here. Actually, the wall of it is shown here. And you have these layers of cells that have accumulated inside, but this is kind of the early in the process. It's the early process where there's no calcium that's formed. But as I'm going to show you in this image, this is a more developed duct. So this is DCIS, but it's early in the process. As it develops, the ducts becomes quite distended. These are DCIS cells, but as the cells die, they form a calcium deposits. And this actually is a calcium deposit. This is what it looks like under the microscope. It's like the calcium doesn't cut because of stone, so it kind of fragments the image. And so you get this accumulation of dead tissue inside the duct, which we can detect as a calcium deposit. And so what you see on the mammogram is not the DCIS, or what you see on the scan is not the DCIS, as you mentioned. Is actually at least when DCIS presents with calcium deposits, what we see is the calcium deposit on the mammogram. We don't see the actual DCIS, but we can in certain instances, and I'm going to show you exactly how that happens. But first, let's move to the next question.
What part do microcalcifications play in the detection of DCIS?
Well, that's exactly the point that we were addressing. So what you have here is an example of a mammogram. It's a mammogram of breasts in women that have had or that have DCIS. What you see are these white specks. Some of them are specks that have formed almost like rods, but the main point is that you see these white specks that have formed. These are calcium deposits that have formed within ducts. You can't see the ducts, although in this example, you kind of get the idea that the duct is lined up along this way because the calcium deposits have accumulated so much that it's formed a rod. But in most cases, it might just be individual specks of DCIS, like you see here, or in this image, individual specks of these calcifications that you see on the mammogram. All of this, this image and this image signifies that around these calcifications, there are abnormal ducts. The radiologist will look at this and says, this is likely DCIS, but we really have to do a biopsy of the calcifications to remove a sample of the calcifications to be sure that the tissue around it is actually DCIS. Sometimes it's actually benign. Sometimes it's the step before DCIS, atypia. But the way to know what it is to get a sample. And so what we're seeing are the calcium deposits. Here's another example of calcium deposits. that are present within the breast, again signifying that there's likely DCIS developing at that site.
Now, can you see these in a dense breast?
Yes, you can. So, and that's why, a lot of people have concerns about mammograms and, about the potential for radiation. But, there's also potential for finding breast cancer at this very early stage. And so that's why we think mammograms remain important. I mean, with most things in life, there's trade-off, there's good and bad risks. And certainly the risk of delayed diagnosis is that this can progress to invasive cancer. The risk or the benefit of diagnosing early with mammography is that it's more likely to be found as DCIS. Now, not all breast cancers develop with calcifications, so doing a mammogram might not help you find it early. But if DCIS is forming, and if calcifications is one of the features that's a part of how it grows, then even in a very dense breast, we can find these white, really, really white specks, which is how DCIS presents. So the density of the breast doesn't really matter. In fact, these calcifications that you see here, this is a dense part of this patient's breast, and those calcifications are forming in a dense part of the breast, yet they still stand out very well. And this would be a fatty part of the breast, dark, but these calcifications, which are white, still stand out against this more white background that you see here. So it just shows how important mammograms are for detecting calcifications, which are a very common way that DCIS can develop.
Are microcalcifications detectable by ultrasound? How do you detect the DCIS that does not form microcalcifications?
So I alluded to the point that mammograms are a great way of finding calcifications. We can sometimes see them by ultrasound, but as you see from this ultrasound image, they're very hard to see by ultrasound. This is a calcification, this is a calcification, but they're so subtle that it's a very unreliable way of finding them. And so, although we will often do an ultrasound of a patient with DCIS to see if there is a mass present, and sometimes when looking for the mass, we see that there's calcifications also. We don't usually use the ultrasound itself as a way of screening for DCIS because it's just such a poor tool for that. However, sometimes DCIS forms without calcifications. It generally is the higher grade DCIS, the intermediate to higher grade DCIS that forms with calcifications because these cells are growing faster and the duct is being distended faster than the blood supply around the duct can develop to grow. And so the ones in the center die because they just don't get enough blood supply. In lower grade DCIS, where the growth happens more slowly, calcifications may form, but they tend to happen later, slower in the process. And so there's a potential for the duct to become distended, to be filled with DCIS cells, but it's possible that there's no calcifications. When we do an ultrasound of these developing ducts, we can sometimes see cancer cells in the duct. So this is basically a duct that's lined up like this, but it's distended in a couple of places by cells that have formed. We don't know this is DCIS, but a biopsy would, this appearance would be suspicious. And so we do a biopsy and we might actually find that this is actually DCIS. And that's really how we go about, utilizing DCIS to detect, to utilize ultrasound to detect DCIS. Again, if someone is having screening ultrasound as part of the cancer detection process, then they actually might see something like this, even if they don't have calcifications. But generally, we would hope that the patient would form calcifications because that would allow it to be detected even earlier on a mammogram, and you wouldn't have to count on looking at the exact right spot to find it on an ultrasound, whereas a mammogram can show you the whole breast, and you could figure out where it is just based upon where the calcifications appear on the breast. One last comment about calcifications, because I wanted to emphasize that calcifications form in the breast is part of a normal process. Tissue that accumulates often develops calcifications. When the breast develops, there are many parts of the breast ducts that die just because that part of the duct is no longer functional. Like it went through as many cycles as the body allowed, and then it no longer makes ducts. It can no longer makes milk. It can either form a cyst, or the cells just can kind of shrink and shrivel up. A lot of times when the cells die, calcium deposit forms in the place where these normal ducts die.
Now, if it's a cyst, can it turn into anything?
Well, most times it doesn't. But
Okay.
one thing that commonly happens with cysts is that when you have a cyst, the cyst is actually the wall of the duct, is that kind of the membrane that surrounds the duct, and it may or may not be lined with living cells. A lot of times the cells along the wall have died, and so the cyst is just kind of the wall with nothing inside, or the wall with very little inside, and it often develops fluid, and even some of the cells which die can kind of settle at the bottom of the duct. The reason why that's important is that when radiologists look at mammograms, they're looking for patterns of calcifications. If calcifications are kind of random, like one there, one there, one there, just like scattered about, we consider that to be normal, random
Benign.
dead cells, benign, not something that requires attention. Sometimes they're in one place, but in the case of a cyst, they actually might line the bottom of a cyst, like if you have a snow globe and you twirl the
Exactly.
snow, and then the snow
And it
settles
sits
to the
on the
bottom.
bottom.
Yes, so that's basically calcium deposits in dead cells that are layered on the bottom of the duct. You turn the breast this way, and they'll layer the other way. The radiologist is looking for this sort of layering process that happens naturally in milk ducts. We consider that benign. But if you have an example, like I've shown you in these recent examples, places where the calcifications are clustered in one part of the breast, and they have like this arrangement where it suggests that there's a process that's happening just here, not here and here and there and there, not randomly, but kind of concentrated in one part of the breast. We call that kind of a clustered process. So when the calcifications are clustered, like they're organizing themselves in this particular area, and they're not layering, that is what is suspicious, and that's what we would lead to a needle biopsy.
Does a cyst say anything about the future? Do you need to be more careful? Do you need to,
Most
do they
cysts,
lead to anything ever?
Cysts can form problems, like a cancer can develop in a cyst, for example, but cysts are often the least important part of the breast. It's the other parts of the breast that are still active, that can still multiply. That's actually where there's a greater risk of a problem. Sometimes cysts can hide a process that's happening next to it. So they can sometimes interfere with detection, but cysts themselves are not usually a problem. That's not 100%. If the cyst is continually growing, or if the cyst is collecting blood and not just simple water, that could be a cause of concern. And sometimes cysts develop because something is growing in the cyst, like a papilloma, and the papilloma is the problem. The cyst is the problem, but the papilloma leaks fluid that causes the cyst to form. And the detection can happen because we detect the cyst that leads us to look at the area that then leads to the diagnosis of papilloma or carcinoma in some cases.
Now, if you biopsy a cyst, does it let the fluid out?
Yeah, it collapses. It's like a
And then-
balloon
Yeah.
but that puncture will eventually heal, and then the
And
cyst
they'll-
might reform.
Okay,
Even if the cyst is benign, that can happen.
okay. How is DCIS detected by a breast MRI? Can an MRI see the calcifications?
So I'll answer the second question first. Calcifications can only reliably be seen on mammogram. They can sometimes be seen by ultrasound if you look at the right spot,
Right.
but they cannot be seen by MRI. But the way that MRI works to help detect cancer is that it's looking for blood flow in blood vessels that are developing around a cancer. For cancers to grow, they may initially be able to grow because they can just absorb oxygen and nutrients that are in the fluid circulating around them. But for them to have successful continued growth, they need to stimulate, release chemicals to tell your bloodstream, your blood vessels, to grow branches that extend to them to support their growth. And this is, you know,
They need a blood supply.
they need a blood supply, and they stimulate your body to make blood vessels to support it. And we call this process angiogenesis or neovascularization. Now, this is part of a normal healing process as well. That's how tissue heals. How you get blood vessels that grow into areas that are injured so that they can be repaired. But it's also how it's the same tool that cancer cells manipulate to help them grow. And so what you have here is sort of a situation where you have initially 4 cells with maybe some small branches that go to them. But as these cell clusters, you see it stimulating your body to form more and more branches of blood vessels to surround it to support its growth. And these blood vessels, when they're happening in a normal situation, kind of have a normal wall and they function completely normal. But in malignant processes, or in many atypical but not quite malignant processes, these kind of accumulating blood vessels aren't fully normal. They're kind of leaky. So the blood vessels, that blood that flows through them, it leaks out more readily than it happens in a normal blood vessels. And because they're leaky, we can sort of exploit that leakiness as a way of finding a DCIS or finding invasive cancer. For example, if you place a dye in the bloodstream and a dye flows through these blood vessels, there's a greater chance that some of that dye will leak outside of the blood vessel and accumulate where those cancer cells are forming. Well, that's actually how breast MRI works, that we give a contrast or a dye called gadolinium into the bloodstream. It flows to the breast or wherever you're looking at. And in areas where there is a malignant or precancerous process forming, generally, we will see the accumulation of this dye that tells us, hey, something is abnormal about these ducts. Even if there's no mass we can see by ultrasound or no calciums we can see by mammogram, we should take a closer look at that spot because it tells us that there is an angiogenic process or neovascular process that's happening there that suggests that there's a normal process in the way.
Is that kind of how PET scans work?
PET scans work differently.
Oh, okay.
PET scans work by taking, let me just step back a moment. In order for normal cells, but particularly for cancer cells to grow, they have to have glucose to consume for energy. And so what the PET scan does is it gives you glucose, but glucose that's tagged with a radioisotope, something that's radioactive, that can be detected on a scan. And so if you give glucose in the bloodstream and it accumulates in a particular spot in the breast, it's telling you that there's something happening in the cells growing there that's causing them to consume more glucose than the cells around them. Cancer cells are really good at collecting glucose, and so they have a greater tendency to concentrate the radioactive substance, and that substance is detectable on a scan. So we can see, cancer cells developing or accumulating glucose using a PET scan. So PET scan is sort of a functional study because it actually tells you that those cells are actively consuming DCIS. The MRI is more of an anatomic study. It's just telling you around those cells, there are these blood vessels. It's actually not showing us the cells. It's showing us the blood vessels that are leaking around the cells. That's what the MRI is detecting. So if you do MRI without contrast, you don't see the vessels. So if you're using DCIS, if you're using MRI to detect cancer, but if you don't use the contrast, it's really a useless study. It doesn't show you anything because it doesn't show you the blood vessels that you're looking for. We need the contrast to find the blood vessels that surround the process.
Isn't there something besides gadolinium they can use? I think
gadolinium is the metal, and there are different formulations of the metal, but at least as far as I know, all of the forms of MRI that's commonly used for breasts use some form of gadolinium. It just depends upon how it's formulated, and the name of the product differs based upon how the gadolinium is organized. But that's how MRI is helpful for finding DCIS. And so what you have here in this image, are two breasts that have two breast MRI images of two breast MRI images showing this area of whiteness, which is actually the gadolinium that is detected by the MRI. It's detected because the gadolinium leaked out of the blood vessels in those areas, and it caused that part of the breast to enhance, meaning that it's more bright than the surrounding tissue. That's why we use the term enhancement. There's increased blood flow indicated by this white area that has developed because the abnormal ducts there have allowed the dye to leak out and accumulate in that spot. And there are different patterns of accumulation that we see. In this example, we would just call this a clumped area of enhancement, so that the cells that are here are sort of growing more of a cluster, and sort of vessels that have leaked out around them are kind of organized in more of a tight, organized area. You also can have a segmental pattern where along the entire milk duct, almost like the whole branch or trunk of a tree, more like a branch of a tree, is diseased. All of the cancer cells there are organized as sort of a branch. And in the breast, you might see this segment or this branch-like process where you see all the cells there that are enhancing, or at least the blood vessels around the cells enhancing. Breast DCIS can appear in one way or the other, but this kind of gives you a sense that it's a sort of a more limited process here. In this patient, it's a more extensive process. It might extend from near the nipple here to the back of the breast. This is a segmental enhancement, and this is, what we might see in a patient with more extensive DCIS.
How common is DCIS?
Well, we have some basic statistics, and this is what we have seen in recent years. About 300,000 plus women diagnosed with breast cancer a year, of which about 48,000, about 50,000 are DCIS. So about 15% of breast cancers today are detected as DCIS. That number varies by the population. As we do more mammogram screening, we detect more cancer as DCIS. In population where mammogram screening isn't as widely utilized, detection of DCIS is a lot less, and we see a lot more invasive cancer. Before mammograms were routinely used for screening in the US, most patients were diagnosed with invasive cancer and incidentally diagnosed with DCIS. But with screening, whether it's with mammogram or with MRI, or occasionally with breast ultrasound, we're seeing the rate of DCIS detection increase.
How is DCIS usually treated?
But we're transitioning now into treatment. So this is sort of a slide from a recent publication that looked at the statistics regarding how DCIS is treated in the US. And what you see is that nearly half of women diagnosed with DCIS in the US are treated with lumpectomy plus radiation, which is basically the same way that we treat invasive breast cancer, which, you might say, why? We can talk about that, the rationale behind that in a moment, but basically that's how it's generally treated. There are also about a quarter of women that undergo a mastectomy, possibly because the area that's affected is so large, like the case of segmental disease as well, where we can't remove it all and maintain the breast with reasonable cosmesis. So in that case, mastectomy might be performed. Other patient might simply want to have a mastectomy, but about a quarter of women have mastectomy alone of one breast. We call that a unilateral mastectomy. I'll just skip here. About 6% of women have bilateral mastectomy. Not necessarily because they have disease in both breasts, but some people decide if you're going to remove one breast, just remove the other one. Maybe they have reconstruction, maybe they don't. But bilateral mastectomy is also seen. About 6% of women have that. There's about 16% of people that have lumpectomy alone. So in the first case, it was lumpectomy plus radiotherapy. In the second case, it's lumpectomy alone. And in general, what determines whether or not radiation is needed partly depends upon patient choice. But sometimes the DCIS is small enough and not aggressive enough and removed widely enough where we find that radiation won't add much benefit. So those patients are more likely to be treated with lumpectomy alone. We can talk about that more in a moment. And then the last category down here is non-surgical treatment, which is either just doing nothing, just observing it, or treating it with anti-estrogen medications, or in some cases, cryoablation, which we'll talk about a little bit more in the presentation. But that's how that's how the treatment breaks down amongst the U.S. population. Now, I have maybe I have a duplicate. Okay.
What is the natural history of DCIS?
So here we go kind of back to this slide talking about the statistics. So the natural history of DCIS is that it starts, and it slowly or quickly progresses from DCIS to invasive breast cancer. And whether or not it happens slowly or quickly or never progress to invasive cancer kind of depends upon the biology of the aggressiveness of the DCIS and how your body inhibits the process. So it's kind of, it's a cooperative thing. It's just, if your lifestyle is something that stimulates cancer growth, it might happen faster. If your lifestyle is something that inhibits cancer growth, it may happen slower. But we know that about half of the 25 to 50% of DCIS will progress to invasive cancer in the lifetime of a typical woman who lives, say, 70 years. In the other part of the population, they'll live their entire life with DCIS but never develop invasive breast cancer. It's either because they just didn't have aggressive DCIS or their lifestyle did not allow it to grow. We don't know necessarily what the answer to that is, but when you do an autopsy, we commonly find DCIS that never progressed to invasive cancer. So it's clear that a lot of DCIS doesn't progress. It's just hard to predict clearly who will progress and who won't. And the other thing to know is when DCIS occurs in the breast and is treated, in most instances, it won't recur. But if it does come back again, about half the time, those recurrences are invasive cancer. So it comes back kind of more aggressively than it did the first time. And it speaks, I think, partly to the biology of the disease. It doesn't mean that everyone who has DCIS will have recurrence, but if 5% of the people have recurrence, then 2.5% of those recurrences will be invasive cancer, and 2.5% of those recurrences will be DCIS. So half of them will be DCIS. So here's that same image I showed you before, just represented kind of differently. And it is a drawing of the breast showing a normal duct, a duct with increased cells, but out calcium deposit perhaps, but this is DCIS, where the cells have accumulated inside the duct becomes distended. Maybe it has calcium deposits, maybe it doesn't. Eventually, you get invasion, where the cancer cells invade the wall of the duct, grow into the tissue surrounding the duct. That's invasive cancer by definition, once the cells are able to survive outside the milk duct. And then potentially it could spread to another part of the body, to the lymph nodes, and that would be a metastatic to the lymph nodes or metastatic beyond the breast. But that's kind of the natural. But whether or not this happens and how fast it happens depends upon a lot of factors that we can't predict. But the general pattern that is seen is something like this. And what we have is a situation where you start off with an abnormal duct, say an atypical duct, and it might develop into DCIS, but just never really does anything. You get a small cluster of abnormal cells. In fact, this is not even DCIS. It kind of develops into atypia, but it never progresses to DCIS. And the person lives their entire lifespan and eventually dies, and they never have even DCIS found. They just have atypical cells. That certainly can happen. We also have, more commonly, people that develop DCIS, but it stays DCIS for their entire lifespan and never progresses to invasive. So she might be diagnosed when she's 80. She has DCIS when she's 80. She probably won't live long enough for it to do anything. If it hasn't yet, it may never develop into anything. And so that's an example of likely a very slowly progressive process. You can also have processes that are slow, where yes, it's heading to invasive cancer. In fact, it becomes very invasive cancer here, but it still is kind of a slower growing DCIS, so slow growing invasive cancer. So it starts off as DCIS here, becomes invasive cancer, but this takes 50 years to happen, and eventually it becomes invasive cancer. And if it's not detected, maybe it could be a cause of death, but in many cases, even that even then it won't necessarily cause death. It just becomes an invasive cancer that
Has to be treated.
has to be treated. And then there are some that progress pretty rapidly, meaning they start off as atypical, they quickly form DCIS, they quickly perform invasive cancer, they form symptoms, and then if they're not treated, they can potentially cause death.
And like HER2 and triple negative.
Yeah, triple negatives are more likely to behave in this way. HER2 positives more likely to behave in this way. Non-HER2 positive, non-triple negatives are more likely to behave in this way, or perhaps in this way. But you can see it's like a spectrum of patterns. Some are more aggressive, some are less aggressive. We don't necessarily know which pattern a person will perform, but once we get a tissue sample, we can start to predict which path that DCIS is on based upon the characteristics of the genes, for example, in that cancer.
Well, then if they can predict it and tell if yours are very slow or slow, can you just wait for and keep tabs on it?
Well, we're not perfect at it, but yes, but that is a question, and you see as we talk about that is being done, but it's not an exact science. Statistics. You don't know which person's gonna. If it says it happens in 20% and doesn't happen in 80%, you don't always know which 20% is going to happen, and you just know statistically it's going to happen in 20%, and it's not going to happen in 80%. But you can't always tell.
The patient can decide whether they want to take the chance or not.
Right. At least if you have something to suggest that it's likely a slowly progressing thing as opposed to fast, you can say, well, I'll take my chances. It seems, in that case, you have evidence to support a less aggressive approach. On the other hand, if it says it's a rapidly progressing thing, then you might want to reconsider that and say, well, it makes more sense now to treat because the odds are not in my favor in this other
And example. If it's slow, do you keep tabs on it like every year, every other year? Something?
For example, yes. So this is a general pattern of natural history. And so, we're going to talk in a couple of slides about sort of how we can use information we can get to determine how to manage it based upon the pattern the behavior that we can predict from the tissue sample that we get.
Can DCIS simply be monitored without treatment?
Well, that was the point you were just you were just asking. And so there actually are efforts to figure out the safety of mating, and also efforts to understand if we can predict which patients are more likely to be slowly progressing ones that can be managed less aggressively versus those that may need more treatment. And so there are two national trials that are ongoing now in the US. One is called the LORIS trial, which is LORIS means low risk DCIS trial. And the other trial is called the COMET trial. And there's also something called the RECREST trial. These are three trials looking at whether or not we can manage DCIS with watchful waiting or with less aggressive treatment as opposed to surgical resection. The LORIS trial enrolled patients with grade 1 or grade 2, so low to intermediate grade DCIS. It did not enroll high grade DCIS. These we know are not likely to be slowly progressing, but they enroll low to intermediate grade DCIS, and they randomize, meaning they equally divide the group into a group that they actively monitor with mammograms at regular intervals or excision. So this one is managed with mammograms, but no surgery. This one's managed with surgery. And over time, we'll look at, the survival of the group, whether or not these patients that were managed non-operatively had progression, whether or not they progressed to invasive cancer more readily than those that had surgery. And that's one of the questions that they're looking at. The COMET trial has the same enrollment criteria, grade 1 and grade 2 DCIS, but it's using surgery versus imaging and anti-estrogen therapy. So anti-estrogen therapy, we know, can inhibit the growth of DCIS, prevent it from developing into invasive cancer, at least in many cases it can. So they're looking at endocrine therapy as a way. Certainly the patients that have surgery and imaging as well, but the key distinction here is one group is managed with surgery, one group is managed without surgery, and instead of surgery, they take anti-estrogen therapy.
I would think they'll do the surgery ones take the anti-estrogen therapy as well.
Not necessarily.
Okay.
Right. But that's kind of one of the questions that we're looking at. Can you do, endocrine therapy instead of surgery as a way of managing the DCIS? And then the last category is the last study that I mentioned is the RECAST trial, which is doing breast MRI. and they're basically giving endocrine therapy and then doing breast MRI to see if they can use the MRI to predict progression. Like if a patient has an MRI and they see DCIS and they give endocrine therapy, and the features of the MRI start to disappear, then it suggests it's a very responsive DCIS that you can manage probably with endocrine therapy alone without surgery. Whereas if you give endocrine therapy and it doesn't appear to slow the process, then that's a patient who likely needs surgery and then would more likely have, because they have a more progressive DCIS. And DCIS that's less responsive to endocrine therapy. And so that's the recast trial. We're going to talk about, cryoablation as well, but in a moment, at least as one of the other strategies for managing DCIS non-operatively.
Are all patients with DCIS treated with lumpectomy advised to have radiation?
Right. So I think I alluded to that point earlier where, we have the majority of women, this would be about, 60% of women in the US is 70%, 65% of women have lumpectomy is the way that their cancer is managed. And about, 40, majority of them have radiation, but a significant of them significant number of women don't. They have lumpectomy without radiation. And so, you can make that judgment based upon the size of the DCIS, how wide the margins are, and whether or not you think the radiation will add benefit. Or you can make the decision by saying, I don't want to have radiation, I only have a lumpectomy. There are ways that you can make that decision that's based upon whether or not the DCIS is low grade or intermediate grade. But there are other tools that I want to point out that can help you make the decision much better. And there's now genomic testing, genomic testing was first started for invasive cancer to see if patients needed chemotherapy. But now we're using genomic testing to see if patients with DCIS benefit significantly from adding radiation. So you can make kind of an informed decision. There's another test, there are two tests that are commercially available. One is DCIS or Decision RT. The other one is Oncotype DX Breast DCIS score. And it basically gives you a score, a global score, which on a scale of 1 to 10 tells you if you're at low risk, like not likely to progress to invasive cancer or not likely to recur. I'm sorry, let me restate that. It looks at the likelihood of recurrence. And it tells you if your likelihood of recurrence is low, you get a score that's between 0 and 3, or it can be moderate or elevated, and that goes up as high as 10. So if you want to ask a question, if I do a lumpectomy, do I need to have radiation? If your chance of recurrence is low, you can say, well, why take radiation if my chance of recurrence after lumpectomy is low? On the other hand, if your risk is high, you might say, well, it makes more sense to take radiation if my chance of recurrence is high after lumpectomy.
Are these only for hormone though, not for like?
No, it's independent of the hormone status.
Oh, so it's good for HER2 and
we're talking
negative or no?
We're talking about DCIS.
Oh, that's right.
So
but still, it's
so
sometimes.
Well, we don't usually measure HER2 on DCIS because it's not an actionable target. We usually just measure ER and PR.
Okay.
And so this test is not appropriate for invasive cancer, although that's being developed. We're talking about patients with DCIS or stage 0 breast cancer, and it looks at not just the ER and PR, it looks at other genes as well to help us get this score. But it can predict your global risk of recurrence, but it can also look at your risk specifically of invasive cancer recurrence. Like you might say, if I have DCIS and recurs DCIS, well, it's still only DCIS, so why bother? I don't want to take radiation for that. But if you have DCIS that's like the recurrence of invasive cancer, then that's more worrisome. And so this test actually helps you sort of group your risk of recurrence. And in this image specifically, it says that with breast conserving surgery alone or lumpectomy alone, your risk of recurrence of having invasive cancer in 10 years is 19%. You might say that's kind of high. Therefore, I would rather take radiation because it can reduce that risk down to just maybe 3%. In that case, you'd say radiation has a lot of benefit to reducing my 20% chance of having invasive cancer in the next 10 years to 3%. But if it says that number is actually quite small, like if your invasive cancer recurrence risk was 5%, you might say, well, that's not worth taking radiation for. I would take my chances. So it helps you understand not just your total risk of recurrence, specifically how likely are you to have invasive cancer in the next 10 years. And that's how these tests can help you determine, whether or not you should have radiation added to your lumpectomy, or whether or not you can be treated without radiation therapy. And so in many cases, I use this to help patients make that decision about the use of radiation therapy. But when radiation is needed, traditionally it's given with whole breast radiation. And so this is basically an image that shows you sort of the area of tissue that's typically covered when radiation is given to the whole breast for people that need to have radiation and only have whole breast radiation as a tool that's available to them. Fortunately, I've been involved in developing one of the partial breast radiation approaches called targeted intraoperative therapy, where we can give the radiation at the time of surgery just to the part of the breast that's affected, not to the whole breast. And so we have data showing that that works just as well as whole breast radiation for localizing the radiation to the affected part of the breast, controlling the risk of recurrence, and minimizing the side effects of radiation. And also doing it in a single treatment at the time of surgery, not as a daily treatment over 16 days, for example, or longer.
But it has to be only in one place though, right? For this, or can you do?
Right, so that's a good point. So if you have a large area DCIS, that likely requires treating a whole breast. If you have lumpectomy, it requires whole breast treatment with radiation. But if you have a limited area of DCIS, then you can have not only a lumpectomy, but a targeted dose of radiation. There are other ways of giving targeted doses of radiation, but they require that you have DCIS limited to just one part of the breast. And so target is one of the tools that's used to giving focused radiation to a small area. And usually we limit it to patients with DCIS measuring 3 centimeters or smaller for this treatment.
And only in one place.
And only in one place, yes.
What is the role of cryoablation for DCIS?
Well, I mean, this is a question that we're trying to answer, and I think we have some of the answers which we're going to share with you today. Obviously, you know that we're conducting a clinical trial looking at the role of cryoablation for managing DCIS. And what we know is that it's, it is potentially a way of managing DCIS, so women with very limited disease in one part of the breast. And that's what the clinical trial is trying to answer. But this is some of the background that I want to share with you because it's kind of why we're thinking about cryoablation as one of the strategies. We know that only 25 to 40% of women with untreated DCIS will progress. So it kind of tells us that we don't really need to be aggressive with surgery or other treatments to manage everyone, that we should be able to find a way, particularly to manage the patients with non-aggressive DCIS or with limited DCIS. We should find a way to manage them so that we can treat the DCIS, prevent it from growing without having to do radiation, surgery, and many other things that are mastectomy, which some people are opting to have. Now, you could also say, well, if only 25 to 40% or maybe 50% of them progress, why don't we just take our chances to see if they progress? Well, we can't predict who's going to progress or not. So another way to look at it is if we had a non-aggressive treatment that we could use to stamp out all DCIS, then we can prevent them all from progressing without having to guess. And maybe cryoablation can be used in that way as a non-operative way to treat the DCIS in one event without requiring that they have medications for 5 years, and therefore kind of safely prevent all of them from progressing to invasive cancer. That's the hope. That's the idea behind looking at cryoablation as a strategy. We know now that, in the US, 2/3 of women undergo lumpectomy radiotherapy, 1/3 undergo mastectomy. Perhaps we can shift a lot of these women to having a non-operative solution that's equally effective and much less harmful, especially if they have DCIS that's small and limited to one part of the breast. So with that backdrop, as you know, we developed the cryoablation as an invasive alternative, as a non-invasive alternative to surgery for managing ductal carcinoma in situ. This is a DCIS cryoablation study. So basically, the study started with enrolling 30 women. That's our goal, to enroll 30 women who will undergo cryoablation to achieve complete ablation of DCIS within the cryoablation zone. So within the area that we target, we're looking at killing the DCIS completely. Because of the mechanics of DCIS, we limit enrollment of the study to women with DCIS 2 centimeters 2 centimeters or smaller, because that's the size of DCS that can be treated with a single ablation most effectively. And that's our primary endpoint, to look at how effective we are at killing DCS in women with DCS measuring 2 centimeters or smaller. And then our secondary objective is to evaluate the 5-year local recurrence rate of invasive cancer. Yes, some of them may have recurrence of DCS, but no one dies from DCS.
Right.
What we want to know is, can we prevent that patient from developing invasive cancer? If not for the risk of developing invasive cancer, no one would need to have any treatment.
Right.
But because we can't predict who's going to develop invasive cancer, we tend to treat all women with DCS to prevent that from happening. Maybe we can treat them with cryoablation. And so we developed this study, and it was funded by several organizations. And as you and many people here know, that they played a hand in getting the study funded through a campaign that was conducted through DTERA, where they matched funds that were raised by people like you and people that are listening perhaps to this webinar. So through monies raised through DTERA and through monies that were raised through Corey, which is an organization that gave us money to cover some of the expenses of the administrative expenses, like the IRB expenses of the trial. And there's also the Helen Reed Breast Cancer Research Foundation, which I'll share with you later. But it was a foundation that's sponsoring this study. And then there's also the company IceCure, whose probes we're using in the trial, who allowed us to buy them at a discount for the trial. They didn't give them to us for free, but they allowed us to buy them at a discount. And so the monies that were raised through this DTERA campaign were used to buy the cryo probes at a discount from IceCure. And that allows us to offer the cryoablation treatment to women without charging them for the procedure. So they are able to have the cryoablation treatment at no cost. And my staff volunteers their time. The company IceCure, provides these discounted probes, and we were able to get the probes through the funds raised through the DTERA. So
I encourage you to do it.
Yes, because
we couldn't do anything with that money. It
yes.
wouldn't be enough to do anything.
So this is how we put it together. So thank you for the encouragement. It shows you how, as a team, we can change how breast cancer is treated. And so that's what we're going to show you in just a moment. So this is further rationale for why we wanted to look at cryo for DCS. We know it works for invasive cancer, so why shouldn't we try for DCS? Most patients with invasive cancer have DCS, so if it's working for the DCS that's with invasive cancer, why shouldn't it work for DCS when it's by itself? From a philosophical perspective, the treatment for DCS should not be more aggressive than the treatment for invasive cancer. As you know, there are now many people with invasive cancer that are being managed with cryoablation alone without surgery. There are people that are being managed with invasive cancer with lumpectomy without radiation. There are people that are being managed for invasive cancer with lumpectomy without lymph node biopsy. That we're, as a medical community, fortunately, making decisions that many people with invasive cancer don't need the aggressive treatments that we've had in the past. As some invasive cancer require aggressive treatment, but increasingly we're recognizing that there are groups that don't need to have aggressive treatment. Yet we're still treating DCS aggressively.
Yeah,
doesn't make sense,
why?
right?
No.
Right. So we need to kind of make the same adjustment, that at the very least we can find ways of treating some patients with non-aggressive DCS with non-aggressive solutions, and cryoablation should be one of them. One of the reasons that DCS was not included in cryoablation studies that have existed in the past is that because DCS doesn't form a match you can see by ultrasound, it's kind of hard to see.
Yeah.
So it's hard to target or localize where to freeze. That's really been the problem with DCS. It's a localization problem. It's not a problem that it can't work against DCS, but still we need to prove that it can't work. We still need to prove that it can work. And so that's what the trial is partly trying to answer, is kind of proving to the skeptics that cryoablation works against DCS and that we can localize it as well. We'll talk about that more in a moment. There's another concern that people with DCS tend to have more than one spot of disease. We call that multifocal disease. And therefore, maybe they should not be considered for DCS because they have a greater chance of multifocality. And although that is true, most of them with DCS can still be treated with lumpectomy. That even though they might have multifocal disease, we can still manage to treat most of them with a limited treatment like lumpectomy. So that means that we should be able to figure out how to identify people with DCIS that can also be treated with a limited treatment like cryoablation. Now, just because theoretically DCIS can be multifocal doesn't mean that we should not offer them a treatment that's more focused. We have the ability to identify those groups with a reasonable amount of success. And so I think multifocality is not really as big of a problem as people used to say it was. And then there's also the issue of, can we effectively treat DCIS with cryoablation, especially if we can't see the edges as well as we can see in invasive cancer. Like when we take patients to surgery, if our surgery is inadequate, we would offer them re-excision to get clear margins. And so the concern is that the re-excision rates are higher with DCIS just because it's harder to find, therefore it's not a good candidate. But if the surgeon who is performing the treatment has a good track record for taking patients to surgery without requiring more reoperations, then that means that that surgeon and the tools that they use to find patients for this treatment should have the ability to find patients that are good candidates for DCIS treated with cryoablation without needing to have additional treatment. So I think this last concern is more an issue of the skill of the surgeon and the tools that they use to characterize the extent. And if they're good at finding DCIS that's small and selecting patients that are good for the cryoablation treatment, then those patients should be offered DCIS as an option, just like we're offering them lumpectomy an option. So we opened the study, and the study is enrolling women age 18 and older with DCIS spanning 2 centers or less based upon mammogram, ultrasound, and if the patient was willing to have it performed, breast MRI. We don't require breast MRI. We encourage it for the reason that I mentioned, that sometimes you can see things by MRI that you can't see by mammography. But if the patient doesn't want to have breast MRI, it's not a requirement. But by whatever tools that are used to evaluate the breast, we need to have confidence that the disease is present only in one spot and it's less than 2 centimeters in size, or at least less than or equal to 2 centimeters in size. We have the patient has to be diagnosed by a needle biopsy, and you have to have no prior history of DCIS or invasive cancer in that breast. They could have any other breast, but not in the same breast. In order for the patient to be enrolled, our radiologists have to review the imaging to make sure we don't see other things that are of concern, that we can agree that the area is 2 centimeters or smaller. Then we have to have that pathology slides reviewed to make sure that they've been diagnosed properly as having DCIS. Since most women don't have DCIS detectable by ultrasound, we may require that they undergo placement of an ultrasound visible marker at the site of the DCIS so that we can find it by ultrasound to target it for cryoablation. And after cryoablation, 6 months later, all patients undergo ultrasound-guided cryoablation, or maybe mammogram-guided cryoablation. I'm sorry, I misspoke. After the patient goes through this evaluation, and if these studies show that they qualify, then they undergo ultrasound-guided cryoablation as a treatment. In terms of post-treatment, after the patient has completed cryoablation, 6 months later, they undergo mammogram, ultrasound, and possibly MRI of the site to characterize the treatment and to look to see if there's any development of disease outside of the area that was treated. They all undergo a biopsy of the cryoablation site with a needle to determine if there's any residual disease at the site. And they then undergo annual follow-up if no disease was found at the site. I talked about the placement of the ultrasound visible marker. The markers that are usually placed by most radiologists around the country after biopsy is done, most of those markers are mammogram visible, but not ultrasound visible. Mainly because the mammogram visible markers are pretty cheap, and that's kind of like the one that they usually stock in their breast center. But there are ultrasound visible markers that are a little bit more expensive than that you can request if you are having a biopsy done, or that we request to have placed for patients that don't have an ultrasound visible marker. And these markers can show up on ultrasound. Like this is one of the markers. It's almost like a little basket with a little metal titanium piece inside. But by ultrasound, that basket looks like a little tube. We can't see the metal part, which is the part that most people have placed. But if you put that metal part inside of this little basket, the basket shows up. The basket is made of collagen, and eventually over time that your body absorbs the basket, leaving the metal part in place. But at least, within a few weeks of the time that the marker is placed, that basket is visible. And so you can have an ultrasound guided cryoablation procedure performed because the surgeon is able to see, that basket pretty well.
Well, if you can see the basket, why do you need the metal in it?
Well, the basket disappears. And so we usually want to have some indication of where the procedure took place. And so that metal part remains because it's going to always be visible on the mammogram in the future as a site, as the epicenter where that treatment was given. You can't rely upon the basket long term because it won't persist. So that's really just kind of a way of kind of housekeeping or accounting to document where the procedure took place. Some people refuse the markers, which, they can, but we usually want to have some indication that, that's the spot. Like even if someone looks at your breast 5 years later, that's the spot where it happened.
Markers can move, can't they?
The markers can move when they initially place, because when you initially placed it, you're placing it into a little tract. Sometimes there's bleeding in the tract. Sometimes the blood pushed the marker. Or when the mammogram, when the biopsy's done, the breast is done, the biopsy's done when the breast is compressed. And then when you release compression, it's like an accordion. It starts off like this, and it comes like that. And the marker can be any way along the track. So that's when marker migration happens. And I'm going to talk about that because it can be a problem. But once the marker is in place, it basically heals in place. The clot forms around it, becomes solidified, the body scars around it, and it's stuck in place like cement.
Okay.
They don't move once they're healed in place. So the migration happens in the first 20 minutes or 30 minutes.
Oh,
It doesn't happen 1 month, 2 months, years later. It just happens early on, right after the biopsy procedure. If it happens, that's when it happens. And so there's another marker that's also used called the hydrogel, which actually stands out a little bit better. This is what the marker looks like here. Has hydrogel with a marker with a metal piece inside. The hydrogel stands out a little better, but these markers are actually slippier. They're more likely to move. So we tend not to like to put these markers in the breast under mammogram guidance, because when the breast is released, this hydrogel is like a slimy gel.
Like a gel.
It's a gel. And so although they look good after a while and they absorb water, so they become more obvious once they absorb water. Once they're in position, they can slip and slide. So I actually prefer the secure mark. And actually this slide is labeled improperly. This is actually the secure mark. This is the hydro mark. So I have to correct the slide. So the secure mark is a slide that one would want to have if you're going to have an ultrasound guided procedure. At least that's what I prefer. So this is basically what we aim to do. This is, we use ultrasound guided cryoablation. We use a single probe. We can usually ablate a volume of 4 by 3 by 3 centimeters. So that's why we want to have something that's 2 centimeters or less, so it fits well within that cryoablation zone. And the treatment usually requires a 10-minute freeze, followed by a 10-minute thaw, followed by a 10-minute freeze of the same site in order to treat the area. And this is kind of a drawing of a cryoprobe. It's the distal part of the probe that freezes the tissue. And so this is that 4 by 3 by 3 centimeter volume that we ablate. So these are, as you know, we did the trial and we've enrolled, and we have a goal of enrolling 30 patients. We have enrolled 14 to date.
Oh, wow.
Which is good, but not so good, because
No,
we need to enroll
more.
a lot more in order for us to get to the answer and be able to publish the results and change how people treat DCIS. We need to have people enrolling, but we are thankful for every individual who did enroll. We offer it to people, but sometimes they just prefer to have surgery instead of ablation, and so we respect their decision. But I always try to encourage suitable patients to enroll in the trial. But I want to share with you some of the preliminary results. 14 enrolled. You can see the ages of those that enrolled. The average age was 66. The median age was 63. You can see the size of DCIS measured by mammogram, MRI, ultrasound. And generally, it was pretty small. But the average size of everyone was 10 millimeters, 10.3 millimeters. Although the largest one we have was 18 millimeters. You see that most patients had estrogen receptor positive DCIS, although some patients had estrogen receptor negative DCIS. So 70% were hormone receptor positive, 21% were hormone receptor negative. And we have a pretty widespread of grade. You have grade 1, which was low grade, 28%, grade 2, which is intermediate grade, 35% high grade, 35%. So we enroll all grades, not just low to intermediate grade.
But you can't do it if you HER2, right? Or triple negative.
Well, we don't care with the
okay.
third, because normally we don't normally test the HER2 for DCIS.
Okay,
If it's tested, it doesn't disqualify you if it's
Okay.
positive or negative, as long as it's just DCIS. Usually HER2 is tested with invasive cancer, but some places will test it in DCIS, maybe for their own research studies. We don't treat based upon that HER2 and part for DCIS. So it doesn't matter.
okay.
You can still get qualified. And so we have had to date, 14 people enrolled, and 10 of them have undergone that biopsy 6 months post-ablation. Remember, everyone else undergoes a biopsy at the site 6 months later. And what we have found is that we've had 10 patients that have completed biopsies. 9 of the biopsies showed no residual DCIS, and 1 biopsy found residual DCIS. And I'm going to explain to you why it happened, because it was a little bit of a surprise, but you'll understand why.
Can it be redone?
Yes, it can be.
Okay.
And there was 1 recurrence outside of the area of ablation, but not within the area of ablation. That was recurrence of DCIS outside the area of ablation. And so let's talk about the results furthermore, a little about the treatment before I get into those 2 cases that I think are notable. We have, in terms of radiation treatment, only 7% of patients opted to have radiation treatment. Even if they were high risk, that didn't mean that they had to have it. In the trial, we leave the decision about radiation to the patient and to her providers, so we don't mandate whether or not she has radiation. But we do perform genomic testing so that they at least have tools to understand whether they're high risk or low risk. The same thing is true for endocrine therapy. We don't require that patients have anti-estrogen therapy. We inform them of their risk and allow them, along with their primary care doctor or their oncologist, to decide. And so that was the breakdown. Only about 30% took endocrine therapy, only 7% had radiotherapy. So we talked about migration of clips. And so that is a problem for surgery, but also can be a problem for cryoablation. This is actually a case of migration of clips. Clip migration may sometimes may sometimes migrate 1 to 2 centimeters away from where they were targeted because of that phenomenon that I mentioned, where they move along the needle tract. And in fact, about 20% of patients have clips that migrate more than a centimeter. I had a case where a patient had a clip placed last week, and it migrated about 5 centimeters along the needle tract. The radiologist had to place a second one, which did stay in position, but the first one migrated 5 centimeters away. But, if your treatment is based upon only the presence of the clip, like maybe there's no calcium left, and you treat where the clip is located, you need to make sure the clip is in the right space, right spot, or you might be treating the wrong part of the breast. In this particular case, this patient had DCIS that was here. She had a biopsy done. The biopsy showed DCIS, but the clip migrated here. It was about 1 centimeter away from her DCIS. She was interested in participating in the trial, so we enrolled her. But we said you're going to need to have a second clip placed, and we're going to do our best to place it in the right spot. But we can't always control that. She had her second clip placed, and it also migrated.
I talked to that person.
Yes, we won't name anyone.
No, I don't.
Right.
I don't remember who it was.
But
I just
anyway.
think they came and told me about it.
And so, and basically, the clip was put in the right spot by the radiologist, or at least what they thought. And when the breast was released, the clip migrated along, and it happened twice. And so we said, well, we can either decide that you're not a candidate for the trial and say, we have to treat you in some other way, or we can try to triangulate, meaning, kind of judge the distance from, the clip to where we think the calcs are, from the calcs to the nipple, from the nipple to the other clip, and with this triangulation, aim for the right spot, which we tried, but we missed. It shows you how kind of inexact that process can be, how really it matters to have a clip in the right spot. And so actually what we did is this was one of the patients who enrolled in the trial who had DCIS still at the site of DCIS that, when she had her 6-month biopsy. That's because we didn't treat her DCIS at all. We treated an area right next to the DCIS because the clip, we couldn't really triangulate it. So it speaks to the importance of having the clip in the right spot. And
Is there
targeting the
any
right
way
spot.
to have a third clip and get it to stay put?
No, you
It's
can't.
just it's gonna do what it's gonna do.
Yeah, maybe if we had it on the other side, then we could have triangulated
Yeah.
between the fourth spot. But it's, it matters the type of clip, but sometimes it matters the nature of the breast. Hers was
Yeah.
close to the nipple, so it's harder to control it. And when it's in the nipple, sometimes those clips migrate more. It's not an exact science, unfortunately. And so that was a successful procedure. It's not that ablation wasn't successful, it just targeted the
It's
wrong
the wrong
spot.
place.
Had we targeted her DCIS, likely she would have been in the group that had no residual DCIS. And then this is another patient who had DCIS here. She actually had a biopsy done of so this is the two views of the same breast showing DCIS. Just want to check the time. And she had biopsies done of both sites. This is her site that shows DCIS. This is the site that was benign. She had cryoablation of the site that showed DCIS, and this is her mammogram done after cryoablation. So this is the part that was ablated. This is the area these are the sort of the indications of the area that was treated. But 6 months later, she developed calcifications over here that were not seen on their mammogram 6 months earlier. And so we did a biopsy of this site here. This was outside the area that was ablated. And the biopsy here, which was 7 to 8 millimeters away from the area that was targeted, also showed DCIS. So this, again, this is benign. This is the area that was ablated that had DCIS. A biopsy of this site 6 months later showed no surviving DCIS. It was benign. But a mammogram done at that time showed that she had new calcifications in the other direction, which the biopsy showed was actual DCIS. And so in retrospect, she likely had DCIS that covered a broader area. Here, it's extended from here to here, but that DCIS had not yet developed calcium deposits. Maybe if she had a mammogram plus an MRI, we would have seen by MRI that something was developing there, but she didn't decline it. But in any case, we were able to treat her with a solution ablation of that new area. And so she, still got a minimally invasive treatment. But, we don't, whether she had been treated with lumpectomy or cryoablation,
would have been the same.
Yeah, it would have been the same. We can't predict what's going to happen in another part of the breast. But fortunately, we were able to successfully ablate the area that we aimed for. So of the 10 patients that we have ablated and biopsied 6 months later, 9 of the 10 had complete ablation of the area that we targeted. 1 patient had complete ablation of an area that was the wrong area. And her DCIS was unaffected because we missed it.
Right.
And, we're now talking about how to manage her with surgery, but we still have to localize the DCIS. So whether or not she's having surgery or cryoablation, we still have to get a marker or wire in the right spot to localize her. And, that's always a challenge, but now you know. But so the conclusion of the trial is that, the failure is due to inaccurate targeting. So targeting is important. Accurate targeting is important. Having a marker in the right spot is important. But the preliminary results show that cryoablation is an effective alternative to surgery for managing DCIS, and we hope to complete the trial. And in fact, if you know someone with DCIS, especially if they have a small area DCIS and they're considering treatment, please encourage them to consider the trial. This is an email that they may contact in order for us to get them enrolled in the study. They don't have to live in Los Angeles. They can just come to Los Angeles for treatment and do all their biopsies and subsequent imaging in their home community. That the only requirement is that they come to LA for one trip for the cryoablation treatment. As I mentioned, the study is sponsored by the Helen Breast Cancer Research Foundation. And my goal is to complete the first 30 and then to enroll more patients, to buy more probes and enroll more patients. And so, the funding that came in through the Terra went to the foundation to buy the probes. Since we want to continue and expand the research, I'm asking people here who want to encourage this research to donate to the Helen Ray Breast Cancer Research Foundation. which you can access online. It's tax-free, tax deductible rather. So if you go to the website, Helen Ray Breast Cancer Foundation, or just email us at info@cryoablation.com, we can direct you to the website. You can also find out more about the trial at this website as well. But this is a trial that's actually, paying the costs for conducting the research, and we thank you for your support of that. There's also a little bit about the ICE3 trial in the few remaining minutes that I want to talk about.
What is the ICE3 trial?
Well, that was a trial of invasive cancer that was recently completed. They completed enrollment. It was a trial that looked at patients with small areas of invasive cancer, 2 centimeters or smaller. They reported their 3-year results recently. They have to wait for the 5-year results, but 3-year results are encouraging. The study enrolled patients that were age 60 and older with single areas of ultrasound visible DCIS that was grade 1 or 2, and it all had to be less than 1.5 centimeters or smaller. Patients underwent cryoablation, and then they underwent follow-up imaging, no biopsy, just follow-up imaging. And the goal was to look at the recurrence rate in the same breast over time. The procedures were all done under ultrasound guidance, like we usually do cryoablation. It was done with a liquid nitrogen-based cryoablation system. The one that we use is the IceCure system, and that was the one that was used in the trial. And although cryoablation can be done with systems that involve use of multiple probes, again, the one that was used in the trial was a single probe system that's used for cryoablation. This is an image showing basically what we aim to accomplish in the trial. This is an ultrasound visible area of disease. This is the cryoprobe traversing the disease. This is the same tumor shown in a different angle with a cryoprobe to the center of it. So that's the idea. We're going to localize the tumor by ultrasound, advance the cryoprobe through it, and then ablate a rim of tissue around it, usually by a zone of about 3 by 3 by 4 centimeters. And in this trial, there were 211 patients that were ultimately screened. 206 were eligible. 206 were enrolled, but 9 were found to be ineligible for various reasons. So there was 197 people that received cryoablation. 3 of them didn't stick to the trial recommendations. So that left 194 patients that were enrolled in that study criteria and followed through with the study protocol. Amongst those patients, the average age was 75, and the median tumor size was about 8 millimeters. So although they roll up to 15 millimeters, most patients had much smaller. The median was 15 millimeters, and most of them, one of the requirements of the trial, they all had to be ER positive, instruments positive. They all had to be lower intermediate grade, so there were no high grade patients. And although lymph node biopsy was not required, about 15% of the patients underwent lymph node biopsies for different reasons. So when you look at the 194 patients, they were followed over a total of 3 years average, and there were 4 recurrences for a local recurrence rate of only 2%, which is generally what we see with lumpectomy. So the study has established that local recurrence rates following cryoablation of these patients treated predominantly with just cryoablation, no radiation, because relatively few had radiation, was 2.6%. There were no serious adverse events or side effects, and the cosmesis was pretty good for the patients, as judged by the patients and their doctors. One thing to note, this is more sort of an aside, but one thing that you should be aware of when people have cryoablation is that there's some residual lump that forms, and that lump is also detectable on the mammogram. And often there's a kind of the dead tumor, what we call a tumor ghost, that persists on the mammogram. This is someone who had 1 year post cryoablation. You see the area that was ablated. You see the tumor ghost that persists on the mammogram. Here's another patient. This is the margins of the ablation, the tumor ghost. And with longer time, the ghost usually dissipates. This is someone 3 years out. You see the clips that were placed at the time of biopsies, but no ghost remaining. But this is something that radiologists just have to expect. With more experience, people will become more and more comfortable reading post-ablation imaging studies, because this sometimes causes concern, but it shouldn't. We, in my practice, we usually recommend a biopsy of the tumor ghost just so that we can establish confidence amongst radiologists that this area is dead, it's not a living cancer. But a biopsy isn't required. And in the ICE3 trial, biopsies were not required. They just followed the patients with imaging to look for recurrences. This is also a post-cryoablation MRI. This is MRI done pre-cryoablation, showing a tumor. MRI performed 3 years post-cryoablation, showing no residual enhancement seen on this patient. And so our last question.
How do you treat larger areas of DCIS?
Well, you know, we have traditional surgery. So this is someone who had a lumpectomy, and you know, if the DCIS for the trial that we're limiting the trial for patients with DCIS 2 centimeters or smaller, the cryoablation trial. But if someone has 3 centimeters or even 4 centimeters of DCIS, we can sometimes treat them with lumpectomy. Often we will offer them lumpectomy as a first choice, and this person had lumpectomy performed through an incision here. But if it's a much broader area, maybe they require, or maybe they simply want to have a mastectomy. And so you can have a mastectomy as performed in this case here. We also have oncoplastic surgical solutions. Oncoplastic surgical solutions employ the use of plastic surgery procedures like breast reduction or breast relift, combined with lumpectomy to allow removal of a larger area of disease while reshaping the breast and creating a nicer looking breast as opposed to a disfigured breast. And so generally what we would do is say remove a much larger tissue, much larger volume of tissue than we do with the typical lumpectomy, and then reshape the breast to close in. And so here's a couple of examples of someone who had, you know, a very large area of DCIS here that had to be removed, but she had the lumpectomy combined with the mammoplasty.
Yeah, I was going to say, did they do the other side to match when they do it? Yeah.
In most cases, we do. Sometimes patients don't want to have surgery on the other breast. They may like the other breast as it is, but the ideal situation would be
insurance covers it.
It does. It recovers a mastectomy. It recovers mastectomy reconstruction. It also recovers reconstruction of the breast after lumpectomy to match the other side. And so she had a cancer operation on this side, which was the lumpectomy plus the reduction. And on this side, she had a reduction as well and lift on both sides to create symmetry. And these are 2 people that chose to have a mastectomy by choice or because maybe the disease was intensive. And both of these reconstructions were implant-based, where we basically removed the interior of the breast. We kept the nipple. This is an implant that's behind the muscle in this case. You can also put the implant in front of the muscle, depends on the plastic surgeon and the patient. But both of them had incisions that were placed along the skin fold under the breast here. It was an inframammary incision. You can see her steri strips along the incision, but she had her breast reconstructed. This patient is pretty, you can still see some of the bruising after surgery. So this was done about, an image is taken about a few weeks after surgery. This is someone a little bit farther out, but again, her incisions are in the skin fold under the breast, and she had reconstruction of both breasts with preservation of nipple and skin of the breast as part of our nipple sparing mastectomy. I have recently written about, and some of you have read about, you know, how we're now using cryoablation to treat not just patients with small area disease, but outside of the clinical trial, using cryoablation to treat much larger area disease. And so basically what we are doing is, in this example of someone with 4 centimeters of disease, we're using several overlapping cryoablation zones to cover a much larger span of disease with a margin. So we have basically 4 centimeters of disease shown here in brown. Our goal to treat this is to ablate a 6 centimeter area of disease. So we have a centimeter margin on the outer ends and maybe up to a centimeter margin on the side ends. And so we can basically do 3 separate insertions of the cryoprobe. In this case, there are 4, but you can basically do as many, in theory, ablations as you can, as is logical, and you can safely perform, that you can financially afford to treat a larger area of disease. But again, this is done outside of the trial. I'm actually going to be writing a paper on treatment of complex cancers with cryoablation, just to kind of provide the medical community with an understanding of how these patients can be treated, because many of them are told that they require mastectomy, although mastectomy might be the treatment that, you know, we would generally recommend. For people that are not willing to have a mastectomy, this provides a way to effectively treat their DCIS without requiring that they have a mastectomy. This webinar has been recorded, and so we'll make it available on the the social media
YouTube.
channels. We'll also, when we post the video, we'll post the date that we'll agree to, and the time that we'll agree to for the next webinar. We haven't chosen a topic yet, but we'll decide a topic between now and then, and
I'll
we'll
post
put
it everywhere.
Yes, and hopefully we'll see you again sometime in May for the next breast cancer Q&A webinar. Thank you so much. Thank you, Sharon. Any closing words?
No, except May, I get to be a whole decade older. Do you realize that?
Decade
Do
older.
you realize that?
I didn't realize that, but
I will be 70.
that is well, that's fantastic. I hope you get to be many decades older in time. But there's
So
also
I,
there's a
but-
blessing in that,
Yes,
obviously.
there is.
So congratulations.
I can't believe I'm gonna be 70, but
I
okay.
can't. Well, 70 years young.
Yes.
Yes. Thank you so much for your time today, and thank you all for your time as well. See you at the next webinar.